Again, request you all to settle down as we start with the second part of our LDP project presentations. And I'd like to call upon Dr. Sagar Pathirage to speak on his project titled Restructuring Screening Process of School Children for Refractive Errors. Dr. Pathirage.
Good morning. Thank you, sir, for the kind introduction. My project is restructuring screening process of school children for refractive errors. As you all are aware, myopia is a global challenge, and myopia is increasing worldwide. And in 2020, prevalence of myopia in the world was 2.6 billion, which was highest in East Asia, with 51.6% of the population being myopic, and in the Europe it was 32 to 36% in different regions. An estimated prevalence of myopia in 2050 is 4.9 billion. Risk factors for myopia include both genetic risk factors like family history and ethnicity, and environmental risk factors like increased near works and limited outdoor time. So the current screening method for refractive errors in school children in Sri Lanka is conducted by the public health inspectors of Ministry of Health using Snellen charts to assess the distance visual acuity, and children with reduced vision is referred to the nearest eye clinic. So the children aged 5, 9, 12 and 15 are screened with 3-year age gaps in between. That is, this gap is mainly due to the limited staff. So for example, if the patient had his first screening at 5 years, then the second screening will be done at 9 years. So after 5 years, then 6, 7, 8, there will not be any screening. But if the child develops refractive error at age 6, it will not be detected until the age 9. The same way, even after 9 and 12, there's 3-year age gap until the next screening. So the objective of this project is to introduce an efficient and cost-effective screening method to detect refractive errors in school children. This project was conducted in Halila MOH area of Badula district, a rural area in Sri Lanka, where health facilities including health staff is very limited. The population of the area is about 600,000, about 1 million, and there are about 200,000 school children studying in 602 schools. The Halila MOH area was selected for the initial phase. There are about 13,000 school children in 71 schools. Prior to starting the project, we got the permission from the Director of Education in Badal district to conduct teachers training education programs and to screen school children. In each school, there are 1 or 2 health promotion teachers, so they are involved in the health related issues in school children. So in the first phase, we conducted the seminar to educate school health promotion teachers of the area about the importance of regular annual vision assessment in children instead of 3-year assessments. And we emphasize the deficiencies of current screening method, and we taught them how to assess vision using Snellen charts, and provided each health promotion teacher with a Snellen chart and advised them to organize a teachers training session in their school to educate class teachers to test visual acuity in children. This is the Snellen chart we used, and it gives simple and precise instruction in local language to how to check visual acuity in children. And this is the first phase workshop to educate the health promotion teachers. And the health promotion teachers, they organize workshops in their schools to educate the class teachers about the importance of regular visual assessments and train them to assess vision using Snellen charts. Then the class teachers were advised to use Snellen chart to check visual acuity in children and refer the those children with reduced vision to the eye clinic. This was coordinated by the health promotion teacher of this school. And those children who were referred to the eye clinic, they had psychological refraction done by optometrist, and either senior medical officer or consultant ophthalmologist did the direct fundoscopy examination, and corneal topography and OCT scans were done where relevant. After assessment by the consultant, spectacles were given and followed up appointments arranged, and patients with suspected keratoconus and progressive myopia, they were directed to the relevant management, specialized management. 54 out of 71 schools in the MOH area completed this project in the first phase. So 8,257 students had visual acuity tested by their class teachers using the provided Snellen charts. 986 children, that is about 12% with reduced vision, were identified and referred to the eye clinic for further assessments. Of those children who were referred, 928 students, that is 11.2%, found to have refractive errors. And 12 were diagnosed with squints, and there were suspected keratoconus in 27 children. Of those who were referred to the eye clinic, 248 children, they already used glasses, and they were followed up in eye clinic for refractive errors. And there were 128 children who were initially diagnosed with refractive errors but defaulted follow-up. And there were 59% of the children were new cases found in this screening. The myopia was the commonest refractive error, and the astigmatism was next to myopia. In conclusion, school teachers are a valuable resource that can be used in the screening school children to identify those with refractive errors. Annual eye screening in school children help to detect progressive visual loss due to myopia and keratoconus at an early stage. Annual vision screening at the beginning of each academic year by class teacher, coordinated by health promotion teachers, is necessary for the sustainability of this program. And this project was conducted in a small area, the MOH area in the Badula district, but in the next phase we are planning to expand it to the whole Badula district. That is, this project was conducted for only for less than 10,000 students, and the next step, second step, that will be 200,000 students, and finally we are planning to expand it to the national level. And this is a photograph of the Badula district, one of the famous tourist attractions, and thank you for the kind attention. Thank you.
Thank you so much. I had one comment while the teachers are being taught how to take visual acuity on Snellen's chart. What possibly can also be taught to them is how to look at behavioral patterns of children sitting in front of them, like somebody who's squeezing their eyes, or somebody who's trying to move forward towards the board.
Absolutely.
Or somebody who has preferential errors between the letter C and the letter O, similar looking letters, which could again be giveaways that these children are having issues with refractive errors.
Yes.
So I think we'll not take questions for this presentation because we are out of time. Thank you so much. So we now call upon Dr. Vanakom Pruksakorn to come ahead and talk on her topic titled Mental Health Promotion to Enhance the Efficient Work of Ophthalmology Residents.
Thank you. Good morning, everyone. I'm Vanakom Pruksakorn from King Chulalongkorn Memorial Hospital, Thailand. My topic is mental health promotion to enhance the efficient work of ophthalmology residents. And I have no financial interest to declare. As you know, ophthalmology training program is challenging. Residents have to deal with the new knowledge, new workplace environment, and also the new colleagues. This induces stress, anxiety, and frustration. which leads to a negative impact on personal relationships and also the professional performance. Our department is concerned about this problem and has found a way to help the residents relieve their negative emotion. So we decided to set up the mindset workshop in improving the well-being and efficiency of the ophthalmology residents. The timelines before workshop were as follow. We're starting with applying for the funding from my faculty and finding the certified emotional helping coaches and discuss about the format of the workshop with them. And I chose the DAS21 questionnaire, which is the free questionnaire to evaluate the stress, anxiety, and depression for both pre and post workshop assessment. And the workshop took place on October 2024. In the workshop, we began with the ice-breaking activity to help everyone relax and connect, and then followed by the small group discussion guided by the coaches, focusing on the identifying their own stress and reframing the negative thoughts. And after that, participants will explore their own, explore to how to shift the mindset through the positive affirmation. And then they enroll in the role playing with the partner. Before concluding the session, the coaches provide the additional guidance how to reduce the stress in the other ways. There were 26 residents join in the workshop, and 83% of them had a positive attitude toward it. For the DAS21 questionnaire evaluation, depression, anxiety, and stress were found decreasing after the workshop. But the small group of the residents and the evaluation period may be the factors affecting the results. In conclusion, a mindset workshop may be one effective tool to improve the residents' emotion, well-being, and promote a more enjoyable and efficient work environment. And long-term evaluation and continuous monitoring are the main keys to support our residents. Thank you.
I think it's a very good topic in today's scenario, and residents are really facing a lot of problems. So it was very good. I think you should continue these type of workshop and put it in the national plan also.
Yes.
And maybe come up with some guidelines which can be adapted through like LDP for other institutes, other countries also. Thank you so much.
Thank
I
you.
think we'll call upon the next presenter, Dr. Prasanna Venkatesh Ramesh.
Can I have the mirror display? AV team? Yeah. Can I have a PowerPoint laser as well? Yeah. Thank you, APAO LDP and the whole APAO team, Moin sir, Minu ma'am, Vivek sir, for this wonderful opportunity. Can I have a laser pointer, please? So my project is on incorporating a novel 4D cost-effective, it's a self-built and a portable mix simulator in a dry lab environment, which is unlocking next level surgical precision. So I got this idea from a mixed scenario case where you can see I'm placing an implant and it just fell off. It was under implant. So I had to implant, I have to give more axial pressure and implant the second stent first. Then I had to remove the other one. And then when I was coming back also, I failed to close the trocar and I lost the stent. So these are some of the common scenarios that a mixed aspirant faces, and then you can see I'm closing the trocar, and then I was lucky in this case, it was one of my earlier cases, but all's well ends well. So mix is a very challenging scenario, so I went back to my drawing board here, and you can see this is the innovation that I have made where it's more like a metaverse, and this is what you see through your eye, and this is what actually people see you, they think you are crazy when they see you from the outside. And not once, twice, but multiple times you can go and practice this in your trabecular meshwork surgery or your angle surgery, and when you do it right, and it's just matter of time, you can go and do it. It's called the cognitive training that I have started at my center in Trichy, Tamil Nadu, and I've also filed a patent and it's pending as well. So the purpose of this is to evaluate the effectiveness of the simulator called the IMG Hollow, and also to identify the features of good mixed simulator, because there is not much of mixed simulation in market as of such. And it was a prospective intervention study with 3 dry lab sessions, 1 dry lab session per month from October, November and December after our Nepal Kathmandu meet, and 30 aspirant fellows participated in this, and this was the composition of the dry lab. So the residents or fellows with no experience did the training, and then a questionnaire was undertaken, and they became group 1, which happened on day 2, and then the real-time mixed surgery was performed, and then the similar questionnaire was actually undertaken. So they themselves will form the group 2 as well after the intervention arm has taken, and the similar questionnaire. The study questionnaire was actually developed after a focus group discussion with in-depth detailed interaction regarding surgical simulations, and it had 10 items pertaining to satisfaction, accuracy, efficacy, hand-eye coordination, safe environment. So these were some of the common questions, like is it adequately prepared, was the hand-eye coordination helped you, the satisfaction levels of the simulator, the visual feedback, and there is a pseudo haptic touch which gives you a sensation of touch when you touch your phone, right? There is a click. A similar sensation gives when you touch the instrument. Confidence level, reducing the likelihood of making mistakes, and what rating would they give, and is the environment safe, and would they recommend. So these were the parameters that were chosen, and they were also divided into quantitative analytic parameters, efficacy, accuracy and user satisfaction. Qualitative based on how are the responses, the negative responses or the positive responses, and where this should actually improve, because they are also exposed to the surgical field. And the question was actually divided into 4 points, very poor to excellent, following the Likert scale, so that we used the standard scale to actually get a methodology arrived. And you can see that 4 into 30 could be the maximum point that one can actually score. If 30 people are all giving 4, it comes down to 120. And then the marks were added and divided by 10, and standard deviation and basic statistical analysis was carried out. And these were the responses of the cohorts of no MIGS and after doing, and these were the responses that you can see, with the lowest rating recorded was actually okay with 12% and 10%. And here also did the simulator help you in hand-eye coordination, with the responses predominantly being excellent and good, and if not slightly improving as well. And this was the third question of the satisfaction levels. Again, the lowest rating was recorded okay, and the excellent percentage 57 that you can see. And then did the simulator provide adequate visual feedback? There seemed to be some poor responses in this, but definitely it was still guiding them. Did the simulator provide tactile feedback? Again, the responses was poor before, but then they felt that the tactile cognition was improving. How much did it improve your confidence? We had some more responses of poor here. And then likelihood of making reduction of making complications, and then the scale of rating it, again the lowest rating was just okay. And then safe environment was a big thumbs up, as well as recommendation was a big thumbs up. Again, going back to the Likert scale, each 10 scale was actually evaluated with a percentage mapping, and each of the 10 questions were divided depending upon the cumulative score. The percentage was arrived by dividing it by 120 into 100, and then the mean was calculated with the standard deviation, which was statistically significant as well, as you can see with the negative confidence interval highlighting that the significant difference, especially combining the above 2 data, showed that the second group was significantly better than the first group. The discussion pertained with that no mixed experience, and after doing, definitely their cognition is improving with these kind of simulative learning, and real-time experiences once they exposed to a simulator gave them a good thumbs up. And some few points which gave a good quality factor was the users felt if you can add annotations, or if you can slightly improve the tactile nature, like synchronizing a tactile system with the HoloLens that we actually collabed with, would really mean a lot. And proper anatomy, expanding the anatomy beyond the angle was one feedback, and expanding it to a wide range of surgical equipments and a wide variety of surgeries, detailed steps of other surgeries were some of the feedback, and these were some of the component 3 of the quality. So to summarize, it's a medical virtual novelty, and it's a self-built portable one made in Trichy, Tamil Nadu, India, easily accessible and portable, improving the quality of care and cost effective and accurate. It's something that is at your hand and with a simple headset, and this application is no financial disclosure, it's free of cost as well, launched at the meshwork of Microsoft. So this is a one of its kind, with, according to my knowledge, a real-time, high-resolution, augmented reality, photoreal visuals for interactive 4D simulation, and especially MIGS, which is making all the inroads in the field of minimally invasive glaucoma surgery. It surgically trains and simplifies learning, and it's available open access, cost effective. And this, my dear friends, is not a science fiction anymore. It's moving into a science-based reality, which is a new world of 4D metaverse that I have coined, and I've also patented regarding the same. So thank you for this opportunity once again. Thank you.
Thank you, Prasanna. Thank you very much. We have 30 seconds left. Any questions or comments from anyone in the audience? I just had one question. The mean standard deviation of the points that you showed,
Yes, sir.
no MIGS and MIGS, that is surgeon not having any prior experience of MIGS, or this is before and after the device usage?
Sir, the left side of the table went with the surgeons not having any experience with the procedure, but they, again, going into the details of it, they are all practicing glaucoma to an extent if you divide them into a different cohort. So they are wanting to do the mixed procedure, but the challenges are we don't have a model, or it's more of like a self-taught or a upgraded surgery. So the same people went into the next cohort in terms of after doing it, how did they feel the simulator? Before doing it, how did they feel the simulator? That was an intervention arm as well, sir.
Right. Thank you so much. I
Thank
think
you.
it's amazing, exciting days ahead
Yes,
as trainees. Sometimes makes me want to become a baseline trainee all over again.
Yes, sir. Then 2010, when I watched Iron Man movie, that was always there with me, sir. And Blade Runner 2047 also, the hologram that came in Blade Runner, that was always there in my mind. Can we really do something like this? And we cracked this code in the year 2021. And now we are working on vertical and horizontal chop as well as capsular access as well.
Right.
Thank you, sir.
Thank you so much. So we'll now call upon Meavuti Soy. I hope I've taken the name correctly. She'll be talking on implementation of artificial intelligence assisted diabetic retinopathy screening in Myanmar.
Thank you. Hello, everyone. It is a great pleasure to present my project on implementation on AI-assisted DR screening in the urban area of Yangon, Myanmar. I have no conflict of interest for this project. Let me begin with the introduction. According to the preliminary data 2024, there are 400 ophthalmologists to serve 52.1 million people of Myanmar. The prevalence of diabetes in suburban area is higher due to economic condition and even distribution of medical resources and education level. Early follow-up and treatment are a great challenge for patients in suburban area. Lack of ophthalmologists, poor awareness of medical treatment, the eye condition of individual in suburban area might be more severe at the time of detection. The development of AI technology assists screening, health, early diagnosis, and treatment of DR amongst the urban population. This is the objective. The objective of the project is to detect different stages of DR in diabetic patients and deliver timely treatment by AI-assisted screening in the suburban area of Yangon. To determine the effectiveness of AI-assisted DR screening in suburban area of Yangon, where there is no ophthalmologist. It is a cross-sectional comparative study of DR screening, which was conducted from November to January 2025 at Township Hospital or suburban area of Yangon. a patient with no type 1 or type 2 diabetes who never done eye screening before, and a patient age between 18 to 85 years were included in this project. Patient who has already taken treatment of DR, poor quality of acquired image, incomplete screening data, lack of AI result or physician result, patient with dementia were excluded in this study. This pilot study as well as the approval from Ministry of Health Myanmar. The data was collected at every Wednesday and non-communicable disease clinic for 3 months. Selena system with portable fundus camera was utilized for screening purpose. Each patient receives a few field fundus photography, which were automatically analyzed by the AI and graded by the human grader, according to EDR system, and later a fundus examination by an ophthalmologist. Patients with detected DR were referred to tertiary hospital for treatment. Questions were asked to test the acceptability of the AI DR screening. Total 207 patients, 414 eyes were recruited in this project. The age distribution ranged from 35 to 82 years, mean age 60.13 years, and median age of 60 years. There were a higher proportion of female participants with 165 females compared to 42 males. The majority of visits, 74.4%, lasted 15 minutes or less during AI-assisted screening. The mean duration was 18.8 minutes. Comparing AI DR screening and ophthalmologist grading, AI detect 350, whereas ophthalmologist detect 362, had no DR or mild DR, and 3 patients compared to 2 had PDR by AI and ophthalmologist respectively. Both AI and ophthalmologists classified 6 patients as moderate NPDR, 2 patients for severe PDR and advanced PDR. The overall agreement between the AI and ophthalmologist diagnosis was high, cover value 0.855, and it suggests that AI strong potential for accurately detecting diabetic retinopathy. In detection of DR, it demonstrates the high agreement between the AI system as compared to ophthalmologist grading of DR with a sensitivity of the 70.8% and specificity of the 100% with high agreement cover value of 0.821. After excluding cases of medial obesity that consider the fundus photo ungradable, the agreement improved to cover 0.915. According to questionnaire, 98.6% of the patients found AI DR screening acceptable and comfortable. 99% had trust in AI-assisted DR screening. All patients believe that it is very comfortable in AI DR screening. 72.5% patients prefer in AI screening, but 27.5% still prefer seeing an ophthalmologist. Most patients, 98.1%, reported no cost for AI-assisted screening compared to patients who spend most of the money on transportation for coming to tertiary hospital for eye checkup. This is a discussion. AI-based DR screening demonstrated multiple significant advantages in clinical implementation. The technology shows an excellent agreement with human specialists, achieving cover values above 0.8 and maintaining high sensitivity and specificity in detecting the DR. In conclusion, the system is also time efficient and more cost effective by reducing the need for specialist referral and encourage early detection in primary healthcare setting. This combination of accuracy, efficiency, cost effectiveness, and accessibility made the AI-based DR screening a powerful tool for detection of DR in the future. Thank you for your attention.
Thank you. Any questions or comments from anyone? So I have one question on your model. So this is something like a screening tool, which is AI based, right?
Yes.
And if I saw the slide correctly, you had a specificity of 100% and a sensitivity of, what was it, around 80 or 90, what was it?
Sensitivity 98.6, I think. You mean that after exclusion of
You,
media
you
history?
showed us sensitivity and specificity of your model.
It's a
Sen-
70.8 and specificity or 100%.
Yeah, so
Yeah.
specificity was 100% and sensitivity was 70 something.
70.8%.
Yeah. So philosophically speaking, when you are looking at a screening model, your aim is to go out and not miss anyone with the disease. So you want your sensitivity to be higher. You would accept some patients wrongly being flagged as a disease positive, who can then come and then you may screen them and say, okay, fine, we thought you had disease, but you don't have disease. But you may not want to accept the other way around. That means you go out, you screen, but you miss someone. So it's a very good model to implement, but you may want to see if you can refine it in a way that your sensitivity rises. Usually AI tools will have high specificity because a high specificity basically means that the AI can pick up a normal fundus, which is baseline. It will always pick up a normal fundus.
Yes.
Now, whether it can pick up few microaneurysms, whether it can pick up few hard exudates, whether it can pick up few cotton wool spots, so that will tell us whether it is sensitive enough. So you can possibly look at the model and see if you can increase its sensitivity, and then it will be a really, very useful tool.
Okay, thank you.
Thank you. So we now go on and call upon Ashraful Ridoy. He will be talking on empowering the future, facilitating first private practice for young ophthalmologists through group practice in Bangladesh. So you'll teach us how to earn money well.
So, good afternoon, everyone. And when I nominated for the LDP, my take home was the personal growth. So, the personal growth could be growing the patient service, communication, and networking, and other is the entrepreneurship. And we believe that by entrepreneurship, the personal growth happens not only along with a group, there will be the personal growth. So, my project is the empowering the future, facilitating the first private practice for young ophthalmologists through group practice in Bangladesh. So we know in Bangladesh that being the ophthalmologist age is 33 to 35. So after being the ophthalmologist, the question comes to mind, where I go for fellowship, shall I do job first, or what will be the private practice? By this time you have family, you might have kid, so you need to have your own earning, you need to have your own station, you have to need your own stability. So these are the very crucial time in this moment, what to do actually. So we start the project that grow your career in ophthalmology to group practice. So we all know in ophthalmology, group practice involves the multiple ophthalmologists working together, sharing facilities, staff, resources to provide the comprehensive eye care and potentially offer the subspecialty services. So it's a one-stop service, every service in one hospital. And what is our purpose of this study? We will form a young ophthalmologist group, establish a private hospital in Bangladesh, we'll go for the group practice and grow career through the professional services. And before starting the project, we need to have some assessment because in Dhaka city, the capital city, establishing a full-fledged subspecialty private hospital, you need nearly 0.5 million USD. So why you need 0.5 million USD? Hospital building, rent, interior designing, machineries and instruments. Though it's a private practice, you need to offer the best possible services to the patients. It's not, you cannot compromise with the services with the patients. So the inclusion criteria of this project, the ophthalmologist below 45 years old still not have their private practice. We to pick up the ophthalmologists who are not in the private practice till now. They completed their subspecialty fellowship or running the fellowship, and the most importantly, they will invest in the project and give their time. Otherwise, the project will fail, we all know. So we first took the 30 shareholders. They invested their money, they invested their time, and now go for the budget. After the invest of the money and after they are committed to give their time, we are lack of budget. We could manage only 50% of the share money or investing money. So what we did, we collaborate with the brand healthcare sector of the Bangladesh. That is what 50-50 investment partnership will be there. So we manage nearly 0.25 million and we will get 0.25 million from them. We will use their name. We will follow the standard operating protocol like them. But believe me, it is more hectic, and it will go for the more cost for our hospital. But what is that? We will have the independent operating board, because I show the previous picture that 30 shareholder will operate the hospital. The investment company will send them reports, but they will not operate the hospital. At Indonesia, I had beard. Right now, I don't have beard. So the beginning. We started with all the subspecialty services and operation facilities for all the subspecialty: cataract, cornea, vitreoretina, glaucoma, oculoplasty, neuro-ophthalmology, uveitis, and pediatric ophthalmology. And we bought best of the best machines. And the most part of this, all the subspecialty, we picked the 30 ophthalmologists who are currently doing the fellowship or completed fellowship, so that in our hospital, we have all the subspecialty available along with the comprehensive ophthalmology. Now comes where you invest. There's a question of money is there. So how we will distribute the disbursement and hospital will get. So when you see the patient, because it's a private hospital, the patient need to give money, and in Bangladesh the health insurance system is not good. So you get the service, you need to pay. So when patient visit our OPD, consultant gets 75%, hospital will keep 25%. A surgery and other procedure, what the total cost, surgeon will get 60%, hospital will get 40%. In investigation, consultant 20% and hospital 80%. Optics and medicine, hospital will get the 100%. All the hospital proportion money, that is actually the running cost of the hospital, which are very challenging to run a full-fledged hospital. And the hospital operating process, how we operate, we have the board of director, and board of director are the ophthalmologist. How much you invest, you see patient, you do operation, you earn money. You take rest at home, you won't get any money. And the supervision of the all department, we like admin and HR, finance, OT, logistic, maintenance, retail, procurement, brand and marketing, all are supervised by us. We are not dependent on any non-medical staff. We have non-medical staff helping us, but all are dependent with us, and appointments of staff are done by the doctors. But so it has some advantage, it has some disadvantage also. The advantage is that the hospital get the good supervision system. There is a transparency of the operating process. We all are shareholder, so we all need to discuss with everything to everybody. But the disadvantage is that all people's minds are not same, so there is a slow decision-making process, and beyond your clinical time, beyond your research time, you need to give extra time for the hospital. So I show the data for 1 year. It is still growing, it is still progressing from March 24 to February 25. In our OPD, you can see when we started, the patient flow was 400, now it's going to nearly 1200 per month. So, and when eye investigations, it's growing, you know, by the time when the time passes, it's growing. And surgeries facilities, we are doing now 150 to 160 surgeries per month. And most important, the financial statement. In first 3 months, we were in loss. The expenses were more than the income. But after last 3 months, the income are more than the expense, but expense did not reduce. Your expense will get high, but when you get for the more income, that will bring you more profit. Then the shareholders are happy, and definitely you will get happy and get more money. So the project is still undergoing, and it should be a long-term project like 5 years, but within this 1 year, what we can see by this project, the overall performance of this private hospital enlightens the potential of the young ophthalmologist, as there is only run by the young ophthalmologist. There is no senior reputed ophthalmologist involved. That is the take home from this project, that no reputed senior ophthalmologist was present of this hospital. Only the young ophthalmologists are running this private hospital. And in conclusion, I want to say, group practice in ophthalmology is a successful system of self-practice development. Patients also get benefited by getting all services under one roof. It helps to maintain good work-life balance. When you want to work, you can work. When you want to take rest, you can go home and take rest. Thank you very much.
Anyone with any comments, questions, or quick financial advice?
Big boss. I have a question because I work in university hospital, so I cannot imagine the
very fantastic work you do. Because I think many doctors have their autonomy and they, for example, if one doctor may be the founder, one of the founder, they invest the money, but after you practice for a period, you find one doctor may not fit the criteria of your private practice, but he is one of the founders. So how can you deal with this problem? Can you get rid of this doctor or?
Okay, the thing is that you just need to, that is the part of the LDP, you need just to build your communication with others. And you saw the picture that all the 30 are the investor. We don't have any consultant who did not invest. You invest, you will be the part of the hospital. If you don't invest any money, you will not be the part of the hospital. So that is the thing. And another thing is that, yeah, what you told, that this is basically the old model of our city, but this difference of these two projects are that there were senior reputed surgeon, they practiced in the institute or other sector, and then they left there and built their own practice. That is the separate thing. But our practice was that you are not doing any private practice, you don't have any experience of the private practice, but let's make a group practice together and let's see after 6 months or 12 months where it goes. And you, with the data, you can see that for the financial purpose and for the patient service, it's growing. Maybe the 1 year is very less to conclude this project. Maybe after 5 years down the line we can have, because now we are in the break-even position. In a month, like we have 25 lakhs our expenditure, we have 28 to 30 lakhs our income. But that's we cannot give dividend to our shareholder. But we need to have a good balance to give the dividend of our shareholder. And also we feel that we need to grow the hospital. Right now we have the space of 10,000 square feet. And we'll, in the last meeting, where before I came here, we feel that we need a space where 25,000 square feet. So these are the things need to change by time. But the good part, but the one part, what your point is that we should make a communication between all of them, and you need to convince, come to us, join us, and you will be benefited.
Thank you.
Yes, ma'am. Yes, ma'am.
Comment. You said you don't have any seniors.
Yes.
So is it going to be a disadvantage, or you would like to include them in the later stages, or?
Okay,
is it advantageous?
that's a very good question, ma'am. Basically, initially, first 4 months or 6 months, it was horrible. It was horrible, and we all feel that it was disadvantage. The thing is that, ma'am, right now, in the exhibition hall, I talked with some glaucoma trade partners. They only know the senior ophthalmologist in the capital city. They don't know any ophthalmologist in our hospital. But what's happened is that where my glaucoma guy is there, he is now trying to practice and improve themselves because he is the head of glaucoma. He needs to pull patient and build his career also. So I don't need any reputed glaucoma surgeon right now in my hospital. I do cornea. I really don't know, but if people want to join, they want to join because it will give you more financial benefit. But for the young ophthalmologist perspective, for the group practice perspective, right now we are not thinking about taking any senior ophthalmologist. We want to carry by ourselves. It's today's plan.
Yeah, that's good.
I think in this model, two other important things very quickly would be, because it's a big group, it might start off at some point, somebody might feel they are not okay with what is happening. So there has to be very well-defined exit clause for anyone who wants to suddenly leave the group because they have invested. They are also stakeholder. So one exit clause should be there.
Yeah,
Second, you gave a disbursement breakup between what goes to the hospital and what comes to the doctor.
Yeah.
So different doctors will have different speeds of practice and different patient load.
Yes.
So would the breakup be spread out evenly between everyone because everyone may have invested equally, or would it be differential because somebody is quote unquote earning more than the other partner?
Yeah.
So these might be important clauses to sort of look at.
Yes, that's a very good point, sir. And we are facing this problem because who gets more patient, who gets more surgery, he gets more earning, and who gets less patient. So we have two systems of disbursement of the patient. The patient know yourself, this patient is yours. So you have more patient, you will get more money. But now the hospital is becoming a brand. So when the hospital is becoming a brand, patient comes to know by this hospital. So we are strict in administration like this because all of the shareholder, we know everything. All of the 30 people know everything. So this patient will split equally to all consultant. It's not getting that he has more patient, he will get more patient. No, the patient who are not knowing the doctor come to knowing the hospital, they get equal disbursement of the patient. That we are strict about it for last 12 months.
Right. So thank you so much.
Thank you, sir.
We'll
Thank
move
you.
to the next speaker. Thank you. So we now call upon Nguyen Hien, and the topic that will be spoken of is establishment of the Vietnam Society of Ophthalmic, Plastic and Reconstructive Surgery. Again, I'm sorry if I pronounced your name.
Names.
Okay. Please go ahead.
Okay. Hello, everyone. My topic today is establishment. My topic today is establishment of Vietnam Society of Ophthalmic, Plastic and Reconstructive Surgery (VISOP). And I'm Dr. Tu Hien from Vietnam National Eye Hospital and APAO Executive Council. There are no financial conflict of interest to disclose. Back to the current situation in Vietnam. In my country now, we have 2,000 ophthalmologists in Vietnam, with the ratio is 18 ophthalmologists per 1 million people. And in my country, we have some sub-society for ophthalmologists, but the biggest society is VOS, where the Vietnamese ophthalmologists can exchange knowledge or share experience. And in my country, we have around 40 oculoplastic surgeons have supply licenses, and I have conduct survey for over 300 ophthalmologists in my country, and so the result of interest in the oculoplastic and reconstructive. In my country, there are some doctors who can perform oculoplastic and reconstructive, including otolaryngologists, dermatologists, common surgeon, plastic surgeon, ophthalmologist who can perform oculoplastic. And the outcome of my survey is so that almost people who want to make the survey or in order to present their result under the scientific conference, and the more detailed question for the attendances about how difficult they get whenever they make the conduct or survey or presentation is that they lack of mentors, lack of methods, lack of data, or lack of patience. And 73% of attendance show the desire to participate on the oculoplastic measure. And in some Asia Pacific countries, there are some countries who their own society for the oculoplastic and reconstructive, and they are member of APSOP. But in my country, up to now, we don't have any. And there's a desire for the attendance who want to attend to some kind of conference. So, thanks to LDP staff as well as my classmates, we have conduct the procedure, the established for VISOP, including 6 steps. First, define objective and scope activities, and the second is establish the founding committee, and the last, and then draft the society charter and obtain approval from relevant government authority, and organize the inaugural congress, and final is register operation and implement program. And now, from the beginning, and now we start in the first step. And we still have a wait time for finish the final step. And since then, we wait for the approval from the government authority. And then we have some preparation activity, including prepare some kind of meeting or conference to connect the ophthalmology in my country, in the north, in the middle, and in the south, even the head of ophthalmology hospital, as well as the medical university. And we also do some activity including lesson for the young ophthalmologists, online or offline, or workshop to transfer skill for the young ophthalmologists. In the international activity, we also connect with the APSOP society as well as join to some international scientific conference. And we also send some young Vietnamese speaker to the Young Innovation Forum, with whom hosted by some my colleague here. And whenever we conduct this study, we found some difficult, including lack of experience, lack of funding, or some skill. And we have asked for the absorb as well as the valuable suggestion from the LDP staff, faculty. And whenever we launch our initial activities for my society, we hope to receive the agreement as well as support and collaboration from both of you here. And thank you for listening. If you have any questions, please ask. Thank you.
So anyone with any comments, questions? I think it's an important endeavor, because as our ophthalmology in every country starts maturing, you always feel that there is a need for subspecialty societies so that you can have more focused discussions.
Yeah.
These societies often are smaller than something like, say, an APAO, so lesser number of people, more likelihood of personally meeting each other and exchanging ideas. So one good way to incorporate is, as you create your structure, obviously it would have the national faculty as a part of different boards, but leading people around the world who are landmarks or benchmarks in ophthalmology or oculoplastics can also be taken on board as advisors, so they can guide you all as to how the society, once it is formed, what should be the path that it should take, and they can handhold your initial office bearers, so that with time then you become a self-sufficient machine, one generation after the other, nationally helping each other. So in the initial days, always nice to see if there can be involvement of some international people as advisory board members.
Yeah, thank you.
Thank you. Thank you for the presentation.
It's also very nice to have these societies so that you can formulate guidelines, protocols, and then you can apply it everywhere.
Yeah, thank you. Yeah.
Very nice presentation.
Yeah, thank you.
So up next, Kendrick. He'll be speaking on use of artificial intelligence and enhancing triage of patients presenting with chronic visual impairment in Hong Kong.
Thank you, Dr. Dave and Professor Chaudhry, for chairing the session. I'd like to thank my mentor, Professor Dasana Yake, who was here just now, but for her very helpful comments. So my project is focused on patient care enhancement, and we're using artificial intelligence, particularly in simple investigations, to be able to triage patients better in our public healthcare system. So this project was very kindly supported by the Health Bureau of the Hong Kong SAR, but we don't have any financial interest to declare. So we have an aging population, and we have a growing incidence of cataracts, and this is worldwide. One of the major issues that we have in Hong Kong is an overloaded public healthcare system. We have about 350 eye doctors in Hong Kong. That's for 7.8 million patients. But if you think about it, that sounds quite good, but if you really look into it, about 2/3 of our doctors are in private practice, and more of these doctors are going to private practice every year. So I really hope they don't listen to Dr. Ash's presentation, because that really gives them a very good idea. But what this means is that 90% of our specialist ophthalmic service is provided by the public hospital, but we only have 1/3 of the specialists manning it. So it's a really overloaded system. And the reason why it's overloaded is because it's free of charge. So patients don't have to pay for surgery. They don't have to pay for their lenses if they go to the public sector. And so they know it's high quality, they know it's free, then why better than to choose it? So how do we limit access, or how do we manage resources? We do it by waiting time. And the problem is that the waiting time, especially after COVID, has gone to the sky. It's basically 2 years, 3 years for waiting time to be seen, and then another 2 to 3 years to actually have the cataract surgery. So you're talking about 6 years after not being able to see. So that has gotten so bad that our chief executive of Hong Kong has actually forced us to increase 20% throughput of cataract surgeries. But how are we going to do this? Now, if you just increase the number of surgeries, you might not actually have that many patients who are eligible for the surgery. And that's because they have to be seen, they have to be assessed, they have to undergo pre-op assessment. And so if you don't increase your capacity to be able to see these patients, you're going to be left with an increased capacity without any patients to do surgery. And so the major bottleneck for our triage and referral is really getting the patients into the system. In order to be seen by our eye doctors in the public healthcare system, you need a referral from a medical practitioner. Now, these are assorted to P1, P2, P3, so urgent, early, and routine. Now, P1 is basically somebody with sight-threatening conditions, for example, a retinal detachment. P2, you're talking about patients who may have something in the pipeline, but not immediately. And P3 are those patients who can wait. Now, this system helps to prevent any irreversible blindness, but it doesn't help in terms of cataract workload because cataract is reversible, and so these patients can wait. Because if you wait 2 or 3 years, or if you do it now, you can still do the surgery and restore vision. And the problem is that if you look at a referral letter, there's an inconsistency in the amount of information that you're getting to do a good triage. So it can be as simple as this, saying patient has blurring of vision, there's no time period, no severity, no visual acuity, and you have nothing else to guide it on, and just give them a routine referral. So what we want to do is to enhance this triage system to see if we can take out those patients with cataracts who can benefit from earlier surgery. Because if you're waiting for 4 years, 6 years, they will have lack of work. They will also have difficulty in mobilization. They have falls, injuries, and hospitalizations. So the benefit of machine learning is the idea that you can train an algorithm to be able to predict things without really teaching them. So the idea is you show them the photo and you give them the end result and they start to make the connections. So they can make better connections than us. And if you look at a fundus photo, this is what we've discovered over time, is that we have family physicians all across Hong Kong. So these are in general outpatient clinics. They all have fundus cameras. So if you're looking at a fundus camera, you're looking at the back of the eye, but oftentimes what you see is blurry vision. And in actual fact, this gives you an idea about how the cataracts are. So having this machine available, you can take the photo without much skill. You can use that to interpret how dense the cataracts are. So the part A is to train and validate the model. Part B is to actually compare it to current practice. So this is the system that we used and the algorithm. So it's basically, we're dividing it into training, validation models. And so we used a data set of about 16,937 fundus images. This was from another project I was involved in for 5 years where we collected that data from those patients. And so we split it up into different validation, training, and testing algorithms. And we also had the output to be either normal, early cataract, or visually significant cataract. And we also used a visual acuity to define that. So normal, no cataracts. Early cataracts means that there is cataracts, but the visual acuity is still better, 20/40 or better, and visually significant cataracts are those that are worse than 20/40. So these are the primary and secondary outcome measures. And if we actually look at the internal validation model, you can see that it performs very well. You have an overall accuracy of about 90%. AUC is actually quite good across the range. And if you look at the external validation where we took a different set, so these are 600 patients that we took from our OPD, you can see also very good results, albeit a slightly lower AUC compared to internal validation. So we put this into clinical use, and what we saw was that the machine was starting to recognize that the area around the disc and the macula was very important in the heat map, and so if it could identify the disc and the macula very clearly, then the cataract was less, and so forth. So if it was very blurred, then it determined a much more likelihood of cataract. And so the real world usage, we plugged it into about 638 patients that we recruited prospectively. And what we found was that if you went for routine referrals, all of these patients would be seen within maybe 2 or 3 years. But actually about 36% of these patients already had clinically significant cataracts, and actually about 4% of these patients saw worse than 20/800, which meant that yes, these patients can wait because they're not going to go permanently blind, but if they're waiting, they're really not functioning in society. So this algorithm really does help in pulling out these patients that our triage system wouldn't be able to pick up. And so the positive effects is that you can use a tool that is widely available and just use an algorithm to be able to help and further triage. So basically you have a different line to be able to increase your cataract output. But the limitations is single condition focus, and it only works in the context of chronic visual loss and not acute visual loss, and it relies on a greater capacity of cataract surgery. So if you have more patients going to the system, you have to have the greater capacity to do surgery. So in conclusions, I think machine learning will really help us in triage, and so it really does help to identify the patients who will benefit from early cataract surgery, and we can incorporate that into a primary care system with the use of this as an aid. So with that, I also do want to mention 2026 APAO. This year has been fantastic. We have a lot of work, so I'll be co-chairing the next session. I'll be looking forward to inviting you all to 2026 APAO. What better way than to go to Hong Kong once, but to go to Hong Kong twice in 1 year. And so we will also have the Asia Cornea Society, which will also be part of in the organizing committee, and we also hope to welcome you there. So one in the beginning of the year and one at the end of the year. Thank you, everyone.
Any quick comments or questions for Kendrick? All right. Anything from your end? All right. I think it's pretty good. Thank you.
I think we are always pronouncing it wrong.
Dharma. Thank you. Good morning, everyone. I'm Dr. Underma Tumuruatar, and ophthalmologist of the First Central Hospital of Mongolia. Today, I'm honored to present my proposal on the establishment. This is not working.
It's not working.
Okay. Today, I'm honored to present my proposal on establishing the eye bank in Mongolia. This project is aimed to improve the corneal care and prevent the avoidable blindness in Mongolia. I would like to clarify that I have no conflicts of the interest related to this project. Introduction was Mongolia has population of the 3.5 million people, with nearly the half living in the capital in Ulaanbaatar, while the 30 to 40 are rural areas. Despite the progress in the general eye care, corneal service remain the development, especially in the government hospital. According to WHO survey, and 252.6 million people worldwide suffer from visual impairment, with the 36 million classified as a blind. Corneal blindness is the significant contributor to this problem, with the 1.3 million cases attributed to corneal scarring and neovascularization. In the Mongolia, 2015 study found the cataracts are leading causes of the blindness, and third one is the corneal blindness in the Mongolia. The main goal of this project is to establish the sustainable and the high quality corneal care system in the Mongolia. This includes the training corneal specialists, ensuring access to proper diagnostic tools and the equipment of the public hospital provide to transplantation service in Mongolia. Around the world, corneal transplantation has transformed lives in the millions of the patient. In the Mongolia, we have a lack of the eye bank, and trained specialists has made this life-changing surgeries nearly impossible for the most patients. Also, in managing bodies, our hospital is First Central Hospital, will oversee this project, ensuring the coordination with the relevant organization. We work at the LV Prasad, and also we work the Health Minister of the Mongolia, also health of the development of our center. In the recent years, our hospital has strengthened the partnership and gained experience from the international institution. Also, we have successfully performed a few corneal transplantation. Also, we do work the cornea transplantation guidelines. Also, we working in the legal environment of the donors cooperation with the governments. Last year, my head of the department and me, and we visited at the LV Prasad, and we are worked together and gained valuable experience and cooperated on the joint efforts. Also, we see how to work of the eye bank in the LV Prasad, because the LV Prasad is the eye bank is the biggest one of the Asia. This is I'm doing the donor tissue in the DSEC preparation of the LV Prasad eye bank. Also, I wrote, our department has partnered with the Ministry of Health. We worked the 3 projects to send the health minister, but we had not selected, but we still waiting. Also, we work at the C International from the Colorado University Hospital, Dr. Eric Litko, who is the most famous cornea specialist in USA. Also, he bring some cornea tissue in our department. We will do the cornea transplantation. All cases I did. Also, this is my cases. We have a lot of macular dystrophy cases. I do the PKP. This is after in the both eyes, after the patient's vision is very good. Also, this is my sick patient and the surgical pseudophakia. This is my cases also. This is my cases TAC. I will do the cornea keratoconus patients. Also, implementing this project, we expect to achieve the following. First is the training for ophthalmologists and residents from the all 21 province and 9 districts and territory hospital in Mongolia. And 2 is the standardized screening, diagnosis, and the treatment for corneal scar. 3 is establishing of the Mongolian first eye bank in here. Thank you so much. It's all my cornea transplantation patients. Also, we do the first time in the government hospital, we did the cornea transplantation surgeries. Thank you very much.
Thank you, Indaba. It's a very good presentation. And as cornea specialist, I feel having an eye bank is something that is very important for a cornea specialist. So, is it going to be one eye bank or is it going to be different eye banks? How many eye banks have you actually planned? One eye bank?
Just the one eye bank.
In your hospital?
Yeah, in because of our hospital is territory, biggest hospital of the government. Most cornea specialists work at the private section. I'm only one in the cornea specialist in the government hospital.
Yeah, and so with the government hospital, because you have other specialities, no other faculties where you can collect the corneas and the quality of the tissue is very good. So it's actually known as the hospital cornea retrieval program. So that is actually works very well. So that is what we have in Nepal also. So in our hospital, we nearly collect about 700 to 800 corneas in a year.
Yeah.
It's very good tissue actually. So it's a very good project and all the best wishes to you for that.
Thank you very much.
Yeah.
Thank you.
So we call upon our next, I think we are short of time also now, Dr. Arjun Shrestha from Nepal, and he's going to present on introducing phacoemulsification in competency-based residency training program in Nepal.
Good afternoon, everyone. I'm thankful to present this project here in front of all of you. So my topic is introducing phacoemulsification in competency-based residency training in Nepal. So this is the hospital where I'm working. I do not have any financial disclosure to conflict of interest to mention here. So coming to the background, cataract surgical rate in Nepal is quite satisfactory. It's 4,600 and it's more than WHO target 3,000. We see the data from Lancet Global Health, where it has compared estimates from population-based survey in 55 countries. Cataract surgery coverage and effective cataract surgery coverage is quite satisfactory. And further, if you see further the range of effective cataract surgery coverage across 4 cataract surgical threshold, different visual acuity threshold is given, and also here also Nepal is doing very good. So we are doing, it's quite satisfactory in terms of different indicators of cataract surgery. If you see the total number of residents intake last year, in 2023, 50 residents were enrolled in postgraduate training program from different university, academy, and National Board of Medical Specialty. So Medical Education Commission is the highest authority to control all the intake of residents in Nepal. But what about phaco training in residency? Unfortunately, none of the residency training curriculum includes phaco training as a mandatory part. So some of the residents might learn phaco during residency, but most of the residents are not exposed to residency training because it's not included in the system. So somebody should take initiative, and this time we thought why not to take initiative. So BPI Foundation, where I'm working as an institute, we submitted the self-appraisal form to medical education to run the postgraduate ophthalmology program. And we got approval, and we are invited for curriculum revision process. And this is the curriculum development workshops where it's more based on the competency based rather than theory based. And we thought this is a good opportunity, and we introduced phaco emulsification as a mandatory part of competency-based research training program, and it was approved by the Medical Education Commission. So far we have already good number of human resource and infrastructure in hand, but training and service delivery is not same. So for patients' safety point of view, we established wet lab and dry lab also. So we thought how to assess the competency. So we developed electronic logbooks, and also we are going to follow the ICO OSCAR, Ophthalmology Surgical Competency Assessment Rubric, which is well accepted. And it consists of different steps starting from dripping to the end of the surgery, that is closing of the wound. And it has, every steps we can assess the competency from novice, beginner, advanced beginner, and competency. It's more often used for immediate feedback to the resident. So for the sake of time, I'm just showing the dry lab video only. Yeah. Sorry. So here, the posterior region is trying to do continuous curvilinear capsular axis. So video may not look so great, but it's just the beginning, and we expect residents to get training for all 3 years. The information what I want to share is the beginning. So this is the continuous curvilinear capsular axis, and this is another dry lab video where next steps division and separation of nuclei with non-dominant hand is shown here. The reason is trying to separate the nuclei with phaco tape and also the second instrument. So in conclusion, we introduced phaco emulsification as a mandatory part of residence training, and is the first ever drafted, documented curriculum in Nepal. Now we are training residents in the step-by-step structure, modules, and phaco emulsification. Hopefully, this initiative will be a catalyst model to replicate in all other training institutes in Nepal in the future. Thank you for listening.
Thank you so much. Any questions for Dr. Shrestha? I was interested in knowing what model is that you were using?
This is a dry lab. It's an old model actually, but it's new for us. It's a Kitara model.
Yeah, I think that's what.
Oh, right.
So, do you buy it, or what do you?
Yeah, we purchase.
Okay, you purchased it. Okay. I think that is a good this thing for training for the residents.
Yes.
Because in Nepal we are actually like doing so much of manual small incision cataract surgery, so we are more focused on that, and we are not training them really for phaco. But I think now we are trying to give them step by step. But I think you have started with the competency based, the wet lab, so I think that's going to be good.
Right. Thank you so much. Thank you.
Thank you.
So I think we are done with all our presentations. Thank you for all the speakers who have come up with such good work, and we wish them all the best in whatever they take their projects ahead as, and all the success. So thank you so much.
I think it's very nice to see, somebody is coming up with a society, somebody is establishing an eye bank and AI models, and it's really nice to see, because when we graduated, I think we had very basic, I think even I had an HCRP as my project, Hospital Cornea Retrieval Program. So I think it's very nice to see come with so many good ideas and so many new innovations with the younger generation, how to become an entrepreneur, like you said. So it's so nice. Congratulations and all the best. Thank you so much. I think we're going to have the ceremony now, or for this one, graduation. Okay. Yeah. Okay.
I think in the lunchtime,
Yeah.
the APO LDP luncheon
Yeah,
is where we all gather. That starts at 1 o'clock.